Hello, everyone, and welcome to our first episode of Infectious Conversations for 2026. I'm your host, Dr. Meera Mehta. I'm a clinical infectious diseases pharmacist, and I've been working at Ruby Memorial Hospital for 10 years now. So this is actually my 10-year anniversary this year. Today, we've got a very special guest on the show. We've got Dr. Zhang. Jack, thank you for being here on the show today.
It's my pleasure. Thank you.
Jack, if you would like to go ahead and introduce yourself, how long you've been at WVU Medicine and where you're from.
Yeah. So, of course, my name's Jack Zhang, and this is actually about half year now where I've been at WVU Medicine, and I'm originally from Cincinnati, Ohio.
Yeah, and Jack is our current PGY2 infectious diseases pharmacy resident. Now, Jack, I always ask this about every guest on the show, but what's a fun fact about yourself?
If I would have to say, I guess a fun fact would be that I played the violin in the Cincinnati Nutcracker
a
few years ago. So that would have to be my fun fact.
A man of many talents. So, Jack, today we're going to be talking about malaria. Now, you've done a lot of work and education about malaria this year, so we thought it would be great to do a podcast on it. Now, malaria, there's about 250 million cases around the world, but it's not something we usually commonly see in the United States. According to the CDC, typically annually, there's about 2,000 cases with about 7 deaths each year. So it's not super common here. But interestingly enough, we do see it sometimes at Ruby Memorial. We did have a case last year. And so because people may not be familiar with the disease state, but we still see it, we thought it would be good to talk about it. So Jack, for those listening that might not be familiar with malaria, what is malaria?
Of course. So malaria actually comes from the Italian root malaria, which means bad air. It was thought to believe that it was the air pollution that caused this disease. But of course, as we know, malaria is actually caused by a parasite called Plasmodium. There are 5 different species of Plasmodium that is known to cause malaria in human beings. Those are Plasmodium falciparum, Plasmodium vivax, ovale, Malaria, and no Leslie. With Plasmodium falciparum being the most severe one out of all of them. Like you said, we don't really see it in the United States. There's about 2,000 cases per year, but overall, there are millions of cases worldwide. 94% of them are actually in the region that the World Health Organization, also known as WHO, in the African region, which is many parts of northern, western, and southern parts of Africa. And then over 74% of those cases are due to children under the ages of 5 years old, and many of them have high mortality rates. So aside from that, malaria is mainly transmitted by a mosquito, the female mosquito of Anopheles species. And it's mainly the female mosquitoes because male mosquitoes typically feed on nectar rather than blood to get their nutrients. And other ways for malaria to be transmitted from one person to another includes receiving contaminated blood products, as well as contaminated organ transplant, or from mother to baby when they're born.
Oh, thanks for that information. And Jack, when somebody does get infected with malaria, what does it do to the body?
Of course. So aside from the symptoms, let's talk a little bit about how malaria actually causes infection in the body. So when the infected mosquito feeds on the human and sucks the blood, during that transmission, the parasite itself actually transmits from the mosquito to the human bloodstream. During this phase, those malaria parasites are actually called sporozoite. And from there, they travel to the liver where they begin their asexual reproduction. During this phase, once they reproduce enough and causes the overwhelming of the liver cell, they actually burst and cause the malaria parasite to be released back into the bloodstream. And during this phase, they're called merozoites. So from this phase, that's when they actually go to the red blood cell. And this is typically when patients become symptomatic because in the red blood cell, they follow a similar pathway as what they did in the liver cell, where they undergo asexual reproduction and begin to reproduce until the red blood cell can no longer contain them, and then they burst, leading to symptoms such as like anemia and low hemoglobin, which can cause many severe disease, as well as it can undergo another pathway where they actually go under a special pathway called, there's not what it's special called, but it can form gametocytes, where this is where mosquitoes that infected mosquitoes come and feed on humans again, can pick up these gametocytes and begin to cycle all over again.
Oh, wow. That's really fascinating. It sounds like it's a very complex process once it goes into the body, but it targets the liver and then spreads in the bloodstream. Jack, you talked about whenever the parasite bursts out from the bloodstreams, typically that's when we'll see some signs and symptoms in the patient. And you mentioned symptoms such as low hemoglobin. There may even be a fever going on. Are there any other signs and symptoms in addition to that?
So unfortunately, very early on in the disease, most symptoms are non-specific. So you may have like your typical chills, fevers, fatigue, the nausea, diarrhea, vomiting, stuff like that. But then later on in the disease, when there are more parasites inside your body, it can lead to more characteristics or symptoms that are more seen with malaria, such as your anemia, your acute renal function being decreased, impaired consciousness or coma, and other stuff like that.
Yeah,
and
respiratory issues,
Correct.
like a wide range of things could occur. So let's switch gears and talk about diagnosis then, because as you mentioned early on in the disease, some of the signs and symptoms are non-specific. So it's really hard to pinpoint and say, okay, this is malaria versus this is another infectious disease that's going on. So talk to me a little bit about diagnosis. What kind of patients would we suspect of having malaria? So let's say they have some of these signs and symptoms, but what other things should we be looking at? Like, should we be looking at travel history, or what other considerations are there?
Yeah, so I would say travel history would be the biggest one, especially if they traveled recently to an endemic area. Of course, there are two species of Plasmodium that can cause relapse. That is Plasmodium vivax and Plasmodium ovale. They can actually lay dormant in the liver cell and cause relapse many months or years later. But besides that, travel history is one of the biggest things. Aside from understanding where the patient originally traveled from, it can also provide information about possible resistance of the Plasmodium species, as well as treatment plan that we may need to use instead of our typical normal treatment plans. But for diagnostic tests, there are multiple, but the most recommended, or I guess gold standard, is your blood film examination, which is basically just putting a drop of patient blood under a film and looking at it under the microscope. There are two different types of smears that they can do in the laboratory. You have your thick smears, which basically helps detect the presence of parasites in your blood. And then you have thin smears, which basically help determine the severity of parasites, so how much parasites are actually in your blood, as well as help identify which species of malaria you have or the patient has. Aside from those, there are two other tests that laboratories can perform, but they aren't as recommended as your blood film examination, reasons being because they have lower sensitivity, lower specificity, or they're just not as accurate as your blood film examination. And those are your rapid diagnostic tests, so something similar to like your COVID at-home testing that you can get over the counter, or you can do your polymerase chain reaction, which basically helps detect pieces and fragments of malaria in your bloodstream.
Okay, so it looks like the gold standard there is actually looking at those blood smears. Jack, the best treatment is always prevention. So before we start talking about how we treat the disease, talk to us a little bit about some prevention strategies.
Of course. So there are I guess we have two different buckets. You have your medication focused bucket and then your non-medication focus. So for non-medications, some prevention methods include just wearing long sleeve clothing and long sleeve pants to help prevent the mosquito from biting you in the first place. Other prevention methods include insect repellent, special netting, and then bed frame or bed window netting to help prevent the mosquito from coming into the place where you're sleeping. Aside from those, it's recommended that you don't go out or like be out from the hours from dusk to dawn, because that's when mosquitoes are most active. And then it's also recommended not to like stay around freestanding water, because that's where mosquitoes like to hang out. So by avoiding using all those prevention methods, you can decrease the risk and likelihood of you contracting malaria. Besides the non-pharmacological options, you have pharmacological options available. So these come in the forms of pills that you can take prior to traveling to the endemic area, especially if you know, preferably as early as possible, as some of these medications need to be taken weeks to before you travel. Others can be taken days before. And then another thing to take into consideration is the patient's adherence, mainly because some of these medications require patients to take a couple of pills multiple times a day or daily, whereas some can be taken once a week. So taking into all those considerations, your clinician or your doctor can help provide the best prevention methods for you when you go travel to the area.
Yeah, definitely. So as you mentioned, Jack, it's really important to talk to your physician or pharmacist if you're going to be traveling. But another really good resource for people to look at is the CDC Yellow Book. So this is a great resource for anyone who's traveling outside of the country to know which diseases are prevalent in certain areas, and it will also tell you what vaccinations you need as well, and then any type of prophylaxis that you might need, such as in the case of malaria, you might need some antibiotic prophylaxis. So thanks for sharing that with us, Jack. So now that we've talked about prevention, let's switch gears and talk about treatment. So how is malaria typically treated once it's diagnosed?
Of course. So aside from getting a good physical history and travel history from the patient to determine whether or not they have malaria, and then doing the diagnostic test to confirm it, once you have all that information and you have suspicion that the patient actually has malaria, the first step is to determine what severity they have. So either they fall under the uncomplicated malaria or complicated malaria. So there are certain different criteria that patients have to meet in order for them to be classified as having severe malaria. Some of those being like your acute kidney injury, your acute respiratory distress syndrome, hemoglobin less than 7. Other factors can be found online, but I'm not going to get too much into that.
Parasitemia is one of them.
Correct.
So you talked about the smears and how much parasite density is able to be determined from the smears, and a certain percentage also would put you in the severe bucket as well.
Correct. That percentage being 5%, but of course that's up to the laboratory personnel to determine how much percentage the patient actually has. But once you determine whether or not the patient has severe malaria or uncomplicated malaria, the next step would be to determine the species of malaria they have. The main reason because that certain species of malaria especially can have resistance towards certain antimalarials. So it's important to know which species they have and especially where they came from, because certain areas of where that's endemic to malaria can have resistance patterns. So by understanding those, that's how your clinician can choose the appropriate anti-malaria to treat you with.
All right. Well, thanks for that information, Jack. And we actually do have a resource online on WVU Medicine's Med Compass, which is where we house our infectious diseases treatment guidelines. We do have one on malaria, so I think this would be a great time to pause and show this guidance document.
All right. So if you take a look at the screen, you can see that we at WVU Medicine have our quick reference guide for malaria treatment. So on the first page, you can see just basic information about malaria, including the background, some symptoms, and diagnosis of it, including the table of contents. And then starting on page 2, that's where we move into the treatment itself. So first, like in the malaria treatment pathway, first you have to have suspicion or have confirmed diagnosis of malaria. And then your first step would be to determine whether or not the patient has severe malaria or uncomplicated malaria. And based on the first box shown up here in blue, those are some of the criteria that patients would have to meet in order to fall under severe malaria. And then whether or not the patient has severe malaria or not, you can follow the pathway and see that most patients will be started on artemether lumefantrine as their medication. And then for severe malaria, shown in the yellow orangish color, aside from starting artemether lumefantrine, there is consideration for starting IV artesunate. IV artesunate is considered a non-familiar agent at WVU Medicine. So if there is suspicion that a patient has severe malaria and requires this medication, it's very important that you involve the ID physicians and ID pharmacists as well as inventory in order to obtain this medication for patient use. And then moving slightly down, here are some information about how to acquire IV artesunate. But like I said earlier, it's very important to get ID physicians and ID pharmacists involved in order to help you get this medication for your patient. And then aside from the normal dosing of artemether lumefantrine. Here's some other dosings for if you have a patient who is a pediatric and their recommended dosing regimen. And then at the very bottom, you have just some other sources of information that you can access or reach out to in order to get more information or help with malaria diagnosis and treatment, including the CDC malaria hotline.
Thank you so much, Jack, for showing us that. As we mentioned, it's not something that we commonly see in the United States, but we do get a case every so often. And so treatment teams definitely can utilize this resource because it's not something you see every day. So it's really good to have a reference for it. You had mentioned that the go-to therapy typically is artemether lumefantrine. That is what we carry on formulary. There are other oral medications that can have activity. However, this agent that we have on formulary typically has activity against all of the species. The two species that you mentioned that could cause relapsing disease months or a certain time down the line, those may need a certain anti-relapse therapy added on. But typically, you would work with the microlab, correct, to determine if you have one of those species and you need to add on anti-relapse therapy.
Correct. So using the thin smear, you can help identify what species of malaria the patient actually has. And if it is identified that the patient has a species due to Vivex or Ovale, those are the two species that can actually cause relapse because they can remain dormant in the liver phase. So if you do have one of those species, aside from using your anti-malarial, so you can use the artemether lumefantrine, or if the patient is not eligible to use that medication, has to choose a different medication, there's another medication that you want to add on to help target that dormant phase. And those two medications are either your tafenoquine or your primaquine. Both of these medications are used. There are certain criteria that patients have to meet in order for them to qualify for using this medication. One of them is your G6PD deficiency. So identifying whether or not the patient actually has this genetic disorder can help determine whether or not the patient qualifies for this medication, because use of this medication in patients who have G6PD can lead to detrimental effects such as hemolytic anemia.
Oh, thanks for sharing that. And in terms of monitoring patients, if we've started a patient on treatment, what type of monitoring parameters would we consider when managing a patient?
For sure. So like I said earlier, malaria can cause many different side effects and symptoms such as your acute renal failure as well as anemia. So some of the laboratory monitoring that you can monitor include your hemoglobin as well as your serum creatinine and BUN, just to see how the patient does during the course of their treatment. Of course, there's always the possibility of monitoring the parasitemia itself, especially for severe malaria, and just seeing how well the patient improves on whatever medication they're put on and whether or not they require IV artesunate. As you remember, the criteria for parasitemia for using or for classifying a patient with severe malaria is greater than or equal to 5%.
Yeah, definitely. And another couple things that come to mind is just looking at resistance, because sometimes there could be resistance to certain anti-malarial agents, and then drug interactions as well, checking through those and monitoring for those as well. Jack, do you have any final thoughts on malaria that you want to share with us?
I believe everything that I've said wraps up malaria pretty well. Yeah. World Malaria Day is considered April 25th, so about 4 months after Christmas. So just a fun fact for everyone.
All right. Well, thank you so much for adding to our knowledge about malaria. And thank you for tuning in to our latest episode of Infectious Conversations. I am your host, Dr. Meera Mehta, and our guest today was Dr. Jack Zhang. And I hope you stay tuned for our next episode. Thank you.